Hello, everybody, everyone that is watching on Instagram, or if you're watching in the Facebook, the Clinical Connections Facebook group. Hello, welcome to today's live training. I'm really excited for today's training to share with you all my thoughts and my feelings about CPGs and post-op protocols. For those of you that do not know me, I am Dr. Jody Miller. I'm a physical therapist and a mentor to PT students and new grads. I've worked in just about every setting that you can think of for PTs. I've done pediatrics to geriatrics. I've done outpatient to skilled nursing, which is where I spent most of my career. I've done travel PT. I've been a rehab director at a skilled nursing facility. I've done adjunct faculty. I've been a lab assistant. And now I own a cash-based practice outside of Tampa, Florida. I work mostly with gymnasts and cheerleaders, but I'm also the owner of Clinical Connections Mentoring. So thank you to everyone that's watching, whether you're watching live or you're watching the replay. If you would, please drop your name in the comments. Tell me where you're watching from. And let me know if you're watching live or if you're watching the replay. I'd just like to know who I'm talking to, who's watching me. So let's get started. So as a new grad, you may feel overwhelmed at times with knowing what to do with your patients and what not to do with your patients, especially with like your post-op patients. And you want to feel competent enough to be able to help them and help them reach their goals. Problem is, you've likely been told that as a new grad, you're on your own now. You should know exactly what you're doing because you passed your boards, you got a license. So you need to know exactly what you're doing. And in order to be a great clinician, you need to load up on more CEUs. You need to have all the CPGs memorized, and you need to know all of the post-op protocols like the back of your hand. This ends up, you probably feel frustrated, maybe deflated, definitely probably feel overwhelmed, and probably a little bit alone. It makes complete sense to feel this way. But what I believe is that just because you've successfully passed your clinicals with all those entry-level marks, graduated from PT school, you've gotten your license, that doesn't mean that you now have to do it alone. You don't have to figure things out by yourself. You don't have to have everything memorized, and you don't have to burn out in the process. I believe that when you surround yourself with mentoring support, guidance by someone who gets you, you'll be able to find the courage and the confidence to get positive outcomes with all of your patients, continue to grow as a clinician, and set up a career that supports a burnout-free work-life balance that allows you the freedom to enjoy your nights and weekends again now that you've graduated, all without having to memorize all the CPGs and all the post-op protocols that exist. So who wants that? Go ahead, drop me in the comments if that's you, if you feel overwhelmed or you feel lost when it comes to CPGs and what to do with or without your post-op protocols. Go ahead, drop a, that wave emoji, drop a me. Tell me if that's you. Do you feel like that person? Just checking all of the chats. See if anybody's dropping any comments. Hello to everyone that has joined recently. So recently I've had a lot of conversations, gotten a lot of questions in my DMs about CPGs and post-op protocols. So I decided, why not just do a live, share all my thoughts with everybody. So let's start first with post-op protocols. So how many times have you gotten a patient on your schedule that just had an orthopedic surgery, maybe ACL repair, meniscus repair, rotator cuff, total hip, total knee, and that patient did not come with a protocol? Tell me in the comments if that was you, if that's happened to you. How many times has it happened to you? For me, it's way too many to count. In 15 years as a PT, I cannot tell you the total number of times that that's happened. So maybe you open their chart and you see nothing. Your stomach sinks, your heart starts racing, start freaking out a bit. You're thinking, oh crap, I don't know what to do. I can't remember what I can and cannot do with this patient. I don't want to mess up their surgery. Surgeon's then going to be pissed. The patient's not going to trust me. Then I'll probably get fired. It becomes this bit of a snowball effect, right? What do you do in that situation? Go ahead, tell me in the comments. What do you do if that happens? You open up their chart and there is no protocol. What do you think you do? I will tell you, step one would be to call the surgeon, right? Cover your ass. CYA. Get that surgeon's protocol in writing and put that directly into the patient's chart. Now, I hear from a lot of students and new grads that they didn't learn any post-op protocols in school, and they're really frustrated about that because there are, questions about protocols on the boards. But here's my take on why I think that happens. Number one, every surgeon is different. Every hospital is different, and your school can't possibly give you every protocol to every surgery that exists. There isn't time for that. It just doesn't make sense, right? It's best to just get the specific protocol from that specific surgeon, right? So even within like orthopedic practices, one surgeon that does ACLs may have a specific protocol and another one could have a different one. So it's impossible to just learn them all, right? Number two is protocols are constantly changing, especially if the surgeon is following the research. Number three, your school's job is to prepare you for the boards, not necessarily the clinic. I'm going to talk about a little bit more about that later. So they likely taught you a very broad understanding of the post-op protocol. For example, ACLs. You probably learned in school that you needed to avoid open chain knee extension until the tissue and the surgical site has healed, because doing that puts too much demand on the new ACL to limit that tibia from translating too far forward, right? Since the school's job is to prep you for the boards, this is likely what you learn to do. Likely is the answer if that question comes up on the boards, because board questions are years behind the research, right? But if you've read any of the ACL research recently in the past few years, we now know that it is actually safe to start doing open chain knee extension even just a few weeks after the ACL surgery. Granted, there's some clinical decision making that has to happen with this, but research has shown that the forces of open kinetic chain knee extension are actually less than the forces of knee extension when you're walking, and patients are allowed to start walking sooner than we've been doing open chain knee extension. There we go. So it's okay to actually start this earlier than what we once thought. So you can see here the latest research says one thing, but likely the board questions are behind on that. So what's the school supposed to teach you, right? So if you're one of those that is frustrated because your school hasn't taught you a lot about protocols, these are probably some of the reasons why. But in general, you can find just about any post-op protocol on the internet. Just type in ACL protocol and you'll get different ones from different hospitals and different surgeons. So why do we need to memorize them, right? If it's just at our fingertips, we can pull it right up on the internet. There really is no need to memorize them. Most of them will follow the same kind of general outline of the protocol, whether it's ACL or rotator cuff. So in the event that you can't find that specific protocol from the surgeon, you get them on the phone, they're just not sending it to you, the internet then becomes your friend. If you're a new grad, you'll find that school teaches you the textbook. But textbook patients are very hard to find out in the wild. I've had maybe 2 textbook patients in my 15 years. So if your school's taught you a protocol, you can use that protocol, but understand that patients are more than their diagnosis of a post-op total knee, post-op ACL repair, post-op rotator cuff repair, right? They have fears, they have emotions, they have very specific functional limitations for them. They have socioeconomic factors, they have family dynamics, all of which impact their progress and their prognosis with rehab, which can all derail you if you're trying to stick to a specific protocol. Okay, so kind of keep that in mind. One last thing on protocols is that not all surgeries need them. I get a lot of questions from students, new grads, about what's the protocol for a total knee or a total hip replacement. These don't need a protocol, right? With the exception of a total hip replacement and the precautions that come with that, whether it's an anterior posterior approach, these patients can progress at their own speed, and they should, right? They are not going to fall into a specific protocol. These patients all need range of motion, strength, balance, gait training, transfer training, proprioceptive training. Nothing's very specific. No specific outline is needed for total hips and total knees. Some patients need more of one thing, like more work on knee extension. Some need more work on gait training. Some need longer periods of time to achieve certain things. Like some people just get stuck at lacking 5 degrees of knee extension for weeks. Some get it right away. Treat the patient for what they need, okay? Which now brings me to CPGs, clinical practice guidelines. These are a hot topic these days. Students and professors love them. They're easy to follow, and better believe they're really easy to teach. They can be really, really helpful for knowing what to do for general diagnoses like low back pain, neck pain, ankle sprains. And before we know it, there is going to be a CPG for every diagnosis that you can think of, okay? Students and new grads like them because it pretty much tells you what to do, right? Let me see, drop CPG in the comments if you love CPGs, right? Right? Students love them, new grads love them. You don't have to think, right? They just kind of tell you what to do. But this is where I think they can be a bad thing, right? I worry that as a profession, we might start to rely too much on them, start to treat patients solely based on the guidelines for that diagnosis. And when that happens, that makes us really too rigid. We become too black and white. And people, our patients, are not black and white at all, right? So CPGs are being created to promote more consistency with treatments across all PTs in the country and the world, right? What they did is they looked at all the most recent research, put it together, and then created these guidelines. And the reason is because there's just a ton of variety in how clinicians treat their patients. One patient can go to, excuse me. So one patient can go to 5 different PTs for the same problem and get 5 different treatment plans. And that can kind of be a problem. So the profession as a whole is really looking for some more consistency across therapists. But this is why new grads love CPGs, because it does all the research for you, spells it out for you, takes the guesswork of how to treat a patient. And when you have this, you then start to feel like, oh, okay, now I can fit in with my coworkers, right? I'm not going to look like I don't know what I'm doing. Helps take away some of that imposter syndrome, right? Who's felt that? Drop in the comments, me, raise your hand if that's one of the reasons why you like CPGs, because it helps you feel like you've leveled up a little bit, you don't stick out as much, you look like you know what you're doing. So in theory, CPGs are a really, really good idea. A patient can go to any PT and get the same treatment plan regardless of where they go, whether they go to, a private practice, a cash-based practice, or a big hospital-based clinic. You can get the same treatment regardless of where you go. So let's take the low back CPG. Talk about that one first. This one has been updated quite a few times, but most recently in 2021. This version, it breaks down the guidelines into acute low back pain with leg pain, chronic low back pain with leg pain, chronic low back pain with movement control issues, chronic low back pain for older adults, and then even post-op low back pain. So a lot of different types of low back pain. But then it goes further and guides you on the best evidence for the interventions to do for each type of those. And it tells you at what stage the research says it's best to do things like joint modes, manipulations, general exercise, or guided exercise, dry needling, nerve glides, traction, McKenzie or MDT, and patient education. So it tells you when is the best time to do all those things based on the stage of their back pain. It even gives you, this is very nice. It does give you like an evidence map for acute and chronic low back pain. But even those maps are somewhat vague. So basically, If you've read the CPG for low back pain, it tells you you should be doing joint moves, exercise, and education for most types of low back pain. McKenzie or MDT is okay to do. And dry needling and traction, there's just not enough evidence right now to recommend it as treatment. But didn't we already know all of that? Like, didn't you learn that in school? Isn't that, like, we knew that, like, none of that really is a surprise, right? Similarly, with the neck pain CPG, this one was most recently revised in 2017, so it's a little bit older than the low back pain one. But this CPG says that we should absolutely be performing assessments that rule out other pathologies and know when to refer the patient out. We should be using imaging, and we should be using self-reported outcome measures to get a baseline status for each patient's functional levels. We know that, right? This also breaks down neck pain into neck pain with mobility deficits, neck pain with movement coordination impairments, neck pain with headache, and neck pain with radiating pain. Then it further goes into acute, subacute, and chronic for each one of those. And then it gives guidelines for when to do joint moves, exercise, and education for each type and stage of neck pain. Basically, it says that for each type of stage, we should be using multimodal approach. Didn't we already know that? Like, that's not a surprise, right? We kind of knew that already. So CPGs are perfect for the biomedical model, right? If the patient has this, then we should do this, and then we should do this, and then you should do that, and boom, they're healed. Perfect in a biomedical model, right? But we all know, or at least we're starting to all learn, that the BPS model is way more appropriate for our patients because our patients are not black and white. They have emotions and they have feelings. They have a history. They have social experiences, all that make them different from everybody else. They're a single person. And that's where I think CPGs are lacking. They don't take that aspect of our patients into account. So I believe that CPGs should be used solely as guidelines, right? They can be a really good starting point and can be used for guidance, but don't let CPGs be the end all be all when you're treating your patients. The absolute best way to figure out how to treat your patients is to listen to the patient that is in front of you in that moment. Slow down, take a really thorough history, listen to what they are telling you about their pain, their functional limitations, the period of time leading up to their pain, and what's been happening through their pain. They will literally give you all the information you need to treat them. Our patients are more than just a diagnosis, like the CPG says. They have emotions like stress and fear. They have past experiences with pain, injuries. They have stories and ideas in their brains about what the pain or the injury can mean for them and how it can impact them. And all of these can influence their pain, what interventions they're going to respond to, and how they're going to progress with therapy. The CPGs suggest that we should do manual therapy, Therex, and pain science education with our patients. And this is absolutely ideal. What happens if your patient doesn't like exercise? They don't believe that manual therapy is going to help. What happens then? Right? And this is where I see students and new grads start to freeze and kind of get stuck and just kind of shrivel back. This is where you start to freak out, right? So who's been there, right? You get that oh crap feeling. The book said this, we learned this in school, the research says this, CPG says this is the best evidence. The patient doesn't want to do that. So now what do I do? Who's been there? Drop a me in the comments or wave your hand. Who's been there, right? Oh crap, I was going to do this because that's what the research says, but the patient's not going to want to do that. Then what happens? The interventions that work best for each patient are the ones that the patient believes will work best, right? I've had patients who've responded really well to manual therapy, and I've had others who have not. I've had patients who've loved doing exercise and gotten amazing results with simply just guided exercises, and I've had others who don't. And then I've had patients who come in to see me with 7 out of 10 acute back pain. I've given them 20 minutes of manual therapy, 10 minutes of some simple movements, all while educating them on what's happening. They leave with 3 out of 10 pain, and the next day they have none. That's happened, right? Every patient is different. This is where you come in, educating your patient, listening to the patient, encouraging the patient, supporting the patient. I say this all the time, but the more you can communicate and connect with your patient, the better results your patients are going to have. So yes, use the CPGs and use the post-op protocols, but use them as guidelines and starting points. The rest, everything that happens after that is 100% up to you, and it needs to be based on the patient that is sitting right in front of you at that moment, telling you what their experience is, what they're experiencing, and what they need from you, okay? This is where you're gonna make a difference with your patients. I hope you've enjoyed hearing my perspectives. These are my perspectives and my viewpoints today. I wanna thank you for coming and listening, whether you're watching live or you were watching the replay. I do invite you, go ahead and drop in the comments, maybe one thing you learned or something that you were like, oh, wow, aha, that makes sense, right? Go ahead and drop that in the comments. And feel free, leave your comments, leave your questions below. I will come back and answer, respond to them, or you can send me a DM, and let's keep chatting there. I keep the conversation going. I like talking about this stuff. So leave a comment, DM me, whichever. But again, thank you for coming, and I hope you have a great day.